We are live.
Good evening all. Welcome to iFocus Online, lecture 292 and 33 on Uvia module. Today we have most awaited session, open quiz on uveitis, and to host it we have even more special speakers, Dr. Parthopratim Dutta Majumder sir from Sankara Nethralaya Chennai and Dr. Abhilasha Baharani ma'am from Rathinam, Hyderabad. May I now request Dr. Parthopratim Dutta Majumder sir to please introduce Dr. Abhilasha ma'am.
Yeah, good evening, friends. It's my pleasure to introduce my young, energetic, and highly intelligent colleague, Dr. Abhilasha Baharani. So she did her MBBS from Kasturba Medical College, Mangalore, and pursued her DNB ophthalmology in Aravind Eye Hospital, Tirunelveli, Tamil Nadu. She did her fellowship in uveitis and ocular inflammation from Aravind Eye Hospital, Madurai. She had done the fellowship in ocular inflammatory disease in vitreoretinal disorder from Royal Victoria Eye and Ear Hospital, Dublin. She is also a FICO and FRCS, Glasgow. She is currently working as a senior consultant and UVA specialist at Neo Retina Eye Center Institute, Hyderabad. She has received several awards. A few of them are Carl Herbert Award from Uveitis Society of India Annual Conference, Award of Distinction and Award of Merit International Ophthalmology Congress, and several other awards. She has published articles in various national and international journals, and she is currently the South Zone representative of the Uveitis Society of India. Over to you, Abhilasha.
Thank you, Dr. Parthopratim, for the kind introduction. And now I'll be introducing Dr. Partho. So I think he has, nothing has been mentioned about Partho, sir. So I will give my own introduction. So Dr. Partho is a senior consultant at the Department of Uvea and Intraocular Inflammation at the prestigious Nethralaya, Chennai. He is an excellent teacher and he brings together a lot of students, fellows, and people who are interested in uveitis in a lot of forums like the Uveitis WhatsApp group, and of course the E-OFTA I'm promoting on iFocus is a very nice platform where you can get quick reads about everything in ophthalmology. And he has, of course, published many articles in various national and international journals. I don't have the numbers here, but I'm sure they are staggering. And he has written several chapters in various ophthalmology books. And it's a pleasure to host this quiz with Dr. Partho. And thank you, iFocus team. Great. Thank you, Santosh sir, for the opportunity. And thank you, Rolika, Shefali, Ruju, and Subhav.
And I would just like to add one part. Thank you, Abhilasha ma'am and Partho sir, for being the lifelines of the entire UVA session. So this is technically the perfect closing chapter or the session for the UVA module, because it ends with both of you who have been our perfect moderators and panelists. Thank you so much for being there for us. So for all those who are waiting for the quiz, let me just tell you briefly about the quiz. Just make sure that you have logged into kahoot.it. The ones who are calling me, I'm just informing you the same. Please log into kahoot.it, because that's going to give you an option to enter the game pin. So I'm just generating the game pin and you will just receive it. Just please give me 2 seconds. Till then, would you like to add some notes for the viewers, ma'am and sir?
So would you like to tell us?
Abhilasha ma'am, there is a little bit of lag in your internet for the first time. Ma'am, is it possible to look into it once? Because your voice is breaking, so the questions and discussion will be a little bit of problem then.
Correct.
Okay, I'll just see what I can do about it. 1 second.
So a little request for everyone, please download the Kahoot app, or you can even log into www.kahoot.it. I will be taking you through it, and so don't worry about it. Just keep that connected. So none of the participants will be there on the Zoom platform as yet. So the ones who are trying to log into the Zoom platform, they will be put in the waiting room. So please, I request you to just download the app so that there is equal distribution of bandwidth to everybody. So, it goes at the same time, the question goes at the same time to everybody, if that is okay with all of you.
Hi, Rolika, can you hear me clearly now?
Yes, ma'am. The video is still sluggish, but your voice is still clear. Voice is clear, ma'am?
Okay. So I have closed everything else and I've asked everyone to switch off their mobiles and
So I'll just share my screen again. So this is the game pin. Is my screen visible?
Yes.
Okay, so this is the game pin. So everybody who's waiting, please put this game pin and join in. That is 7594240. And your names will start popping up here once you put your nickname for it. I advise you to put your entire name so that it will be great. Yeah, so Deepika is the first one to log in. That would be great if you guys keep logging in with your names. So we'll keep waiting till everybody joins in, and till then we can take in some tips from Dr. Partho sir and Dr. Abhilasha ma'am regarding the UVA sessions in general. Or we can just say a feedback, ma'am. How was it? How did you enjoy being the moderators for the UVA session? Should I take it as silence speaks like more than 1,000 words? Partho sir, Abhilasha ma'am, can you hear me?
Yes, I could hear you. I was just figuring out if everything is...
Yes, ma'am. Okay.
Yes. So, what was your comment, Rolika?
My
Sorry.
comment was that, what was your feedback on being the moderators, and how did you enjoy the session? And if you have any tips for the postgrads?
I think Partho sir is the best person to give postgrad tips because he's actually into teaching and he's doing a lot of teaching work for everyone. But for the post-graduation students, I think that they should really take interest in studying and study everything with interest. Don't take it as, oh God, I have to study this and I have to study that. So once you take interest, everything becomes interesting. That's
Yes,
my...
ma'am.
That's my tip. And don't try to mug up things at the last moment and read every day.
Correct, Abhilasha. I think Abhilasha has summarized it very nicely. So let's start. I think I'm afraid we may actually exceed.
No, sir, not a problem. Actually, some people are still joining. We'll just give it them some time. Otherwise, they will end up missing few questions. If that's okay, sir.
Yeah, fine, no problem.
G.
So some tips from you.
Nothing. I
how
think
to make perfect diagrams. You can take those tips from Partho sir. He has the perfect diagrams that you look at. You can even go on eOpta and you can see those diagrams are very reproducible. So you can actually look at them and put them in your answers. I have that suggestion. So I've been kind of looking at the diagrams with hearty eyes. So they're pretty interesting. Go and take a look at it. Is that right, Partho sir?
Yeah, I think Rolika, we can actually tell them about the rules and regulation of the quiz also. I think there will be 4 rounds. So
right, sir.
First round, First and second round will be conducted by Dr. Abhilasha. The first round, the topic is the clinical scenario or clinical picture of any uveitic entity. The second round will be is on imaging. So Dr. Abhilasha will ask you question based on some imaging findings in uveitic entities. The third round is all about laboratory investigation, where we'll be asking question on from the laboratory investigations of various uveitic entity. And most of them are multiple choice questions only. And the last round, the fourth round will be on treatment of uveitis. So there will be 6 questions each in each round. So in total, there will be 24 questions. Is there any negative marking, Rolika?
No negative marking, sir. So, and just to add on, like the leaderboard will show up on after every question, so that you guys have an idea about where you are standing. And it's also very time sensitive. So if you answer quickly, then you have higher points allotted to you. So you can, up your score up, you can go up the leaderboard very easily if you are pretty fast, but at the same time, accuracy really matters. So accuracy and, spontaneity is what gets you to the quiz. So I shall go proceed with the quiz, sir. Maybe begin, sir.
Yes.
Right. Just to add on, the winners and their prizes are still not announced. So let's wait for the final announcement, and I probably and hopefully will have it by the end. So we'll let you know. So just a brief again that this is on kahoot.it, and just a second. So the quiz will be played on Kahoot. As sir has said that there will be 24 questions and each question will have 4 possible answers. The time to answer each question is 20 seconds, and once the time lapses, the selected answer will be considered final. And if none of the options are selected during the time frame, auto pass will be logged. And again, Quizmaster's decision will be final. So let's move on and start off with our first question. Over to you, Abhilasha, ma'am.
Sure. So round 1 is clinical. So I'll be talking about some clinical features of common uveitic diseases. So we go on to the first question, Malika.
Yes, ma'am.
So question 1, about HLA-B27 associated uveitis, which is true? The uveitis is usually granulomatous. The eyes are typically white. Fibrinous anterior chamber reaction is a feature associated with positive rheumatoid factor. 4 seconds. So we've got, so the correct answer is C, fibrinous AC reaction. Of course, the uveitis is usually non-granulomatous. The eyes are have circumciliary congestion, we all know, and it is associated with a negative rheumatoid factor. That's the reason we call it seronegative uveitis. And we have on top Dr. Aditya, Deepika, HY, somebody is HY, Anushri, and Radhika. Well done. Go on to the next. Yeah, so this is 1C. So as I explained, fibrinous AC reaction is the correct answer. And here, if you see the picture, you see fibrinous AC reaction. There is a hypopion and there is some fibrin stuck on the anterior lens capsule. And fibrin with cells is 4+. We know we should remember grading of cells also. So we'll go on to the next question. Question 2, about Fuchs heterochromic iridocyclitis, which statement is false? Copious nodules are seen. There are abnormal vessels seen bridging the angle of the trabecular meshwork. Cataract is seen in 50% of cases, and increased vitreous loss during phacoemulsification is common. So time is up, and 32 have got it right. Excellent. So we'll go on to the again, and Dr. Aditya is again on top. Very good. Others have to buck up quickly. We go on to the answer, please. So the answer is 2D. Actually, iris nodules are common. And these vessels that are seen at the angle, they tend to bleed during cataract surgery, and that is called Amsler sign. We all know cataract is very common at presentation. However, cataract surgery is usually uncomplicated because it's a posterior subcapsular or usually soft white cortical cataract. So that's about Fuchs. Now we'll go on to the next question in the interest of time. So question 3. Severe vitritis is a feature of which one of the following? CMV retinitis, serpiginous choroidopathy, presumed ocular histoplasmosis, or acute retinal necrosis? 5 more seconds. So very good, 41 have got it correct this time. And again, Dr. Aditya is again leading the scoreboard. So we'll see the explanation. So the answer is 3D. So CMV retinitis is seen in immunocompromised. That's why vitritis is absent. Serpiginous and again POHS, there is no vitritis. And acute retinal necrosis is seen in immune-competent individuals, and vitritis, retinal vasculitis, and periretinitis is a common feature like we see in the picture here. So always remember, vitritis is a feature of ARN and not CMV. So that's about it. Next question. Which one of the following is false about CMV retinitis? So spontaneous resolution is seen in about 30% patients without treatment. It is rarely seen in patients with CD4 counts of more than 50, causes full thickness retinal necrosis, and frosted branch angiitis is a known clinical feature. Which one is false? So only 21 have got it correct this time. So again, Dr. Aditya has read a lot of uveitis. He's coming first. So we'll go on to the answer. Yes, so the answer is A. Now, treatment is always required. CMV retinitis is a serious condition. It is seen in immunocompromised and it doesn't resolve on its own. Patients have to be treated with intravenous, oral, and intravitreal antivirals. And there is severe systemic immunosuppression. It is a risk factor, and the characteristic white lesion surrounding the blood vessels called frosted branch angiitis is a common feature. So that's the answer to question 4. Now question 5, which one of the following is true about Behçet's disease? So we had a very good class there. Uveitis is always unilateral and recurrent, usually seen in immunocompromised males. Persistent CMV is an important cause of vision loss, and it is characterized by peripheral choroidal infiltrates. Time is up. Okay, so 27 have got it right. And again, Dr. Aditya is leading the scoreboard. Now, Dr. Ashna has come very close. And now we'll go on to the answer, please. So the answer is C. Now, the first point, that it is not unilateral and recurrent. It is actually bilateral recurrent non-granulomatous panuveitis with occlusive retinal vasculitis. And it is an autoimmune multisystem inflammatory disease seen in immunocompetent males, not immunocompromised. Persistent CME is a very important cause of visual loss in these cases, and retinal vasculitis and retinal infiltrates are seen and not choroidal infiltrates. So this is a picture of Behçet's uveitis, where you see multiple retinal infiltrates and retinal vasculitis. So thank you. Now go on to the next question. So question 6, this is the last question of the clinical round. All of the following are features of intraocular tuberculosis except broad-based posterior synechia, retinal vasculitis and perivascular infiltrates, stellate capes and choroidal granuloma. Okay, time's up. Very good. 54, almost all have got it correct except a few. So we'll go on to the answer. Of course, Dr. Aditya again, Ashna is catching up quickly. We'll go on to the explanation. Yes, so the answer is 6C. Stellate capes is a feature of Fuchs uveitis, and we see broad-based posterior synechia. And here, this is a choroidal granuloma. You can see the OCT. There is a large choroidal granuloma, and this is the contact sign that you see. This is the granuloma, and here you are seeing retinal vasculitis. Now, round two. Round two is imaging. Imaging is a very important part of uveitis now. So first question on imaging. Starry sky on FFA is a characteristic feature of which one of the following? BKH, sarcoidosis, posterior scleritis, or CSCR? This is easy. I think all of you should get it correct. Yes, excellent. 53 have got it right. So VKH is the answer. We'll go on to the explanation. Again, Aditya is on top and Ashna has gone to number 3, but now we have Anita and Shruti Nair. Very good. Well done. So VKH, now there are numerous hyperfluorescent pinpoint foci of leakage at the level of the RPE, which result in the classic starry sky appearance on FFA. And this is classically described in BKH. It's not seen in sarcoidosis or the posterior scleritis. So this is the starry sky appearance, and you have to keep it in mind. Now, question 8. Which one of the following does the image represent? Snowballs in sarcoid intermediate uveitis, headlight and fog in toxoplasmosis, intraocular foreign body, or cysticercosis? Wow, excellent. 60 have got it correct. So again, Dr. Aditya is there on top. Then Shruti, Anita and Ashna, very well done, all of you. So we'll go on to the answer. Now, the active lesions have a classic headlight and fog appearance in toxoplasmosis because there is focal, white, fluffy lesion in the retina, often adjacent to an old pigmented scar, which is visible through a dense vitritis. So when you see through a dense vitritis, this focal lesion looks like a headlight in the car headlight in the fog. So that's the correct answer. And this is a very important clinical sign in toxoplasmosis. Next question. Which one of the following does the image represent? Fundus autofluorescence image of serpiginous choroiditis, early phase FFA picture of serpiginous choroiditis, late phase FFA picture of serpiginous, or infrared image of serpiginous choroiditis? Again, very good. 42 have got it right. Not bad. Aditya is still leading. He's almost, almost there. But again, round 3 and 4 are also there for the others to catch up. We'll go on to the explanation. So, fundus autofluorescence is a topographic mapping of lipofuscin distribution in the RPE. And in serpiginous choroiditis, the inactive lesions are hypo-autofluorescent and active lesions are hyper-autofluorescent, as you see in this picture. This is not an FFA picture because you don't see any vascular filling, and this is not an infrared imaging because in infrared imaging you see the choroid more clearly. So that's that about question 9. We'll go on to question 10, last 3 questions of round 2. Which one of the following does the image does not represent? So this is a swept opacity of BKH syndrome. There is evidence of retinitis. It shows a boggy and thickened choroid, and it shows subretinal fluid with septae and hyperreflective dots. Time's up. So 43 have got it correct. I was expecting a little more. So we'll go on to the explanation. Again, Aditya is there on top still, and Anita is still hanging on. Very good. We'll go on to the explanation. So this is a swept source OCT of the BKH syndrome, and there is no retinitis. You see the retinal architecture is almost maintained. It shows a boggy and thickened choroid. You don't see the choroidoscleral margin. So it's a thickened choroid, and it shows subretinal fluid with septae and hyperreflective dots. So these are characteristic features of BKH on OCT. We'll go on to the next question. So which one of the following statements is true? Multifocal choroiditis FFA shows early hypo and late hyperfluorescence. The lesions are in the retina. Early phase FFA is used to look for CME, and FFA shows choroidal neovascular membrane. That's the picture. Excellent. This was a little tough question, but 51 have got it correct. So the answer is multifocal choroiditis FFA shows early hypo and late hyper. And of course, Aditya is leading. And now we have Radhika also at number 3 spot. Anita is at number 2. Very good.
So just a tip for the others who are trying to beat Aditya here, try to answer really quickly. You get like around 900 to 850 points, and that keeps you going up the scoreboard. So over to you, ma'am.
Yes. Thank you, Rolika. Now the answer is multifocal choroiditis FFA shows early hypo and late hyperfluorescence, as you see in this picture. Now, this lesion is not in the retina, it is in the choroid, because you see the blood vessels are passing over the lesion. Flower petal leak on FFA is typical for CME, and it is seen in the late phase, not in the early phase, and there is no hyperfluorescent membrane seen in this picture. So now we go on to the last question of this round. Which one of the following statements is true? This is a normal OCT angiography scan. The outer retina slab normally shows vascularization. The image shows lacy wheel neovascular network in the outer retina, and inflammatory CNVMs are generally type 1. Time's up. Very good. This was a tough question, and 44 have got it correct. So we'll go on again. Aditya is leading round 1 and round 2. So now we'll go on.
Now they're listening, ma'am.
Yes, yes. I think round 3 and round 4 they can make up. So Himani is making a comeback with 3 in a row. Excellent.
True
We'll go on to the answer. So this is an abnormal scan. This is not a normal scan. We don't usually see vascularization in the outer retina slab, and we see a lacy wheel neovascular network. So OCTA is very useful for inflammatory CNVMs, and the inflammatory CNVMs are usually type 2. They are not type 1. So they are seen between the neurosensory retina and RPE. Type 1 is seen below the RPE. Okay. So this is all we have for round 2, and so we'll move to round 3. Dr. Partho is there with the laboratory investigations.
So thanks, Abhilasha. So now we have identified the clinical lesion, ordered the ancillary investigations, and now we'll go with the laboratory investigations. So let's put the first question. So the first question is, in which of the following conditions ELISA will not be useful? Your options are A. Toxoplasma, B. Toxocara, C. HIV, D. syphilis. So the correct answer is syphilis. ELISA is basically an enzyme-linked immunosorbent assay. It's a laboratory technique to used to detect the antibodies or antigen in a sample. However, ELISA is not typically used for the diagnosis of syphilis. We use one treponemal and another non-treponemal test for the diagnosis of syphilis. Let's see the scorecard. Great. So we'll move on to the question number 2 of the laboratory investigation round. So which of the following is not the common HLA association? The first one is HLA 1809, serpiginous choroiditis, HLA B27, psoriatic arthritis, HLA B51, Behcet disease, HLA DR4, Boston-Haraja disease. Which Excellent answer. I think I've correctly identified. 49 people have given the correct answer. Perhaps HLA A29 has the strongest HLA association with any known clinical entity in medicine. Approximately 95% of the patients with birdshot choroidal retinopathy carry the HLA A29. So it's not HLA serpiginous choroiditis. It should be the birdshot chorioretinopathy. So we'll go to the next question. Let's see the scorecard. Great. Aditya, then followed by Shruti, Radhika, and there is someone PG Ups. I don't know what is the meaning of that. Anyway, so let's go to the next question. So, which scenario you don't need to order a laboratory investigation in uveitis? Option A, trauma. Option B, acute uveitis. Option C, first attack of anterior uveitis. And D, all of the above. Oh, surprised. So 43, yes, all of the above. So what happens under normal circumstances, laboratory investigations are not done in trauma, fuchs uveitis, and fast attack of non-granulomatous acute anterior uveitis. However, you must remember that in case of diagnostic dilemma, one must investigate accordingly. It's not that there is no standardized criteria or guideline that says that these are the condition investigations are contraindicated. It's a general perception that these are the conditions, it's local, the diagnosis does not require any laboratory investigation. So let's see who has scored highest in this. Great. Aditya is still on the top and others are okay. So next, go to the next question. So which of the following association is false? ELISA, toxoplasma, converting enzyme and vaginal granulomatous serum lysozyme and sarcoidosis. Again, very easy question. Correct answer. So what happens? Angiotensin converting enzyme, it is secreted by macrophages within the sarcoid granuloma, and the level of ceramycin reflects the total body mass of the active granulomas present in the body. So ceramycin can be raised in multiple conditions, not only in sarcoidosis like miliary tuberculosis, Hodgkin disease, even the patients with diabetes mellitus, systemic lupus erythematosus, but there is no clear-cut association with vaginal granulomatosis. So the answer is vaginal granulomatosis. Let's go to the next question. Which of the following parameter is not included in the international study group criteria for basic disease? Option A, eye lesions. Option B, HLA-B51. C, pathology test. Option D, skin lesions. Correct. 35 people actually correctly answered. So HLA-B51 can be found positive only in 50 to 70% of the patients. That's why it is not included in the criteria for Behçet disease. That means HLA-B51 does not rule in or rule out Behçet disease. Let's see the scorecard. I think Aditya is still rocking. 13,653. Others need to come. So here is my next question. Probably the last question of this laboratory round. So it's a long one. Just read carefully. A 9-year-old child with bilateral iridocyclitis and macular edema has presented to the clinic. Her fundus examination is unremarkable except for macular edema. Her parents informs about malaise, fatigue, fever, and weight loss, for which they consulted a pediatrician nearby, and preliminary blood investigation shows elevated blood urea, nitrogen, and creatinine. Which investigation you will perform? Monto test, MRI brain, serum B2 microglobulin, or torch titers. So let's see correctly. Option C, only 25 people have answered it correctly. So let's see the scorecard. Yes. So patients with tubulointerstitial nephritis and uveitis syndrome, that is popularly known as TINU, will have elevated beta-2 microglobulin levels in their urine and serum. So the correct answer is beta-2 microglobulin. So let's move on to the last round, the round 4, treatment of uveitis. It's not my specs. Disclaimer. So the which of the following immunosuppressive is not an antimetabolite? A, azathioprine. B, cyclosporine. C, methotrexate. D, mycophenolate mofetil. Very easy question. Those who have attended Dr. Amit Khosla's class on immunosuppressive. Correct answer. So what happens? Antimetabolite work by mimicking the molecule that a cell needs to grow. So they act as a fraudulent agent. So what happens? The antimetabolites, they trick the cells into taking a drug instead of their normal building blocks of genetic material such as RNA or DNA. So in that scenario, the cyclosporine is not an antimetabolite. What it is basically a calcineurin inhibitor. Now, what is calcineurin? Calcineurin is an enzyme that activates T cells. Now, we all know T cells plays a key role in cell-mediated immunity. So the correct answer here is cyclosporine. Let's see the scorecard. Wow. Now I think we have to keep Aditya in a different category, and then you have to calculate the winners. So,
but at the same time, the others like really trying hard to answer spontaneously so that they buck up. And I would just like to add that Aditya was constantly there for all the lectures, and I think that is what is helping him. He has heard all the lectures throughout. Is that right, sir?
Yes, and he's like the wall. No, everyone is trying to replace him. It's impossible. Well done, Aditya. So our next question is, which of the eye drop is formulated as emulsion? A, prednisolone acetate 1%. Option B, dexamethasone sodium phosphate. Option C, difluprednate. Option D, homatropin. You have to identify which one of them is an emulsion. No, option A is not correct. 39 people, strange. They have prednisolone acetate it's not an emulsion. It is suspension. So correct answer is option D. So an emulsion is basically a mixture of two or more liquids that are normally unmixable. and that gives them that liquid and liquid phase separation. So an emulsion has theoretically, it has a better stability in storage and homogeneity of the preparation. So difluprednate 0.05% is an example of oil in water emulsion. So the correct answer is C. Let's see the scorecard. Wow. Same here. So who is PG ups? Is it possible to know, Rolika?
So we'll know by the end, like when they log in on Zoom. So
This
then
is
we will be able to tell.
like pen name, they are using some name.
Yeah. So like they have the option of nicknaming themselves. So it's PG ups. Unless they message me, I won't know about their names.
Yeah, but they have to show some identity or something.
We'll do that. So by the end, the ones who win on the scoreboard, we'll invite them on the Zoom platform to join so that they can be introduced.
Great. So let's go to the next question. It inhibits the enzyme dihydrofolate reductase. That means the production of the tetrahydrofolate, which in turn inhibit the production formation of thymidine. So you have to tell which drug I am talking about. Option A, methotrexate. Option B, trimethoprim. Option C, pyrimethamine. And option D, all of the above. Great answer. Option A, 34. Then can I see the result? Yeah, option D, 25. So which is correct? Correct answer is all of the above. Now what happens here? All of these drugs are inhibitor of the dihydrofolate reductase. So what happened? Methotrexate inhibits the dihydrofolate reductase in human. The trimethoprim inhibits the dihydrofolate reductase in bacteria, and pyrimethamine inhibits dihydrofolate reductase in protozoa. So all of the above are the correct answer. Let's see. Oh.
So, wow, Shruti Nair, you're really neck to neck with Aditya now.
Let's see.
Yeah, and the one tip that I would like to give you guys is when in doubt, it's always all of the above.
Not always. Anyway, let's see whether we can beat Aditya. So our next question is little tricky. The next question is, which was the first agent to be injected through intravitreal route? First, option A, corticosteroid. Option B, ganciclovir. Option C, air. Option D, anti-VEGF. Let's see. Option A, 20 people clicked corticosteroid. Option B, 12. So the correct answer is air. So the A's intravitreal injections was first introduced in 1911 when Ohm gave an injection of the air in the vitreous humor to repair a case of retinal detachment. So the first injection of air was used as a treatment modality for the retinal detachment. So in that way, the first intravitreal injection is air. So now let's move on to the fifth question of the treatment of uveitis. It's still neck to neck fight. So let's see. Now, through which option A, subcutaneous, option B, intravitreal route, option C, subconjunctival, and option D, oral route. So the correct answer is option C, though there are reports of topical and subconjunctival application of the methotrexate, but they are not the ideal route for the use of the drug. So option C is the correct answer, subconjunctival route. Let's see the scorecard, Rolika. EG ups.
I think by the end also the leaderboard is taking like extremely interesting curves, sir.
Exactly. Very difficult to
Yeah.
predict the next.
Aditya was like, wait a second, I'm gonna go escape out.
So
Great.
the last question of this quiz. So it's a very easy one. Which cycloplegic is not used routinely in the treatment of anterior uveitis? Option A, atropine. Option B, homatropine. Option C, cyclopentolate. Option D, phenylephrine. Correct answer is option C, because cyclopentolate is considered as a chemoattractant for the inflammatory cells. So that's why they are not used for the treatment of anterior uveitis. Let's see the final scorecard.
Any guesses? So at the third position, we have Ashna. At the second position, we have Gautamar.
And
The first position, we have Aditya.
congratulations, Aditya, Gautam, and Ashna. Excellent.
Yeah, and we have our runner-ups as well, PG Ups and Nick. So I request all of you to please send me send me a message on WhatsApp so that I can share the Zoom link with you. My number is 8826612008. I repeat, 8826612008. So quickly send me a message and I'll send you the link. And Sunilji, please request you to admit them as soon as they join in. So this probably is the first quiz in which the first position has been constantly placed by the same person. We've had so many quizzes, but this has been the 1% person who's been there. So would you like to also just discuss the difficult questions over here? As you can see, these were the difficult questions and few people answered it.
I think most of the question we have discussed. The first, which is the most difficult? Difficult question 9. So which cycloplegic is not used? I think that's because most of the time we see that in our routine practice also. So many people are using cycloplegic like cyclopentolate. But it's not a very correct practice because cyclopentolate has been seen to be a chemoattractant. So that means if you are using the drug, it will attract more inflammatory cells. So that's why use is actually not recommended. What is the next second question? We can't see that. Yeah, question Fuchs heterochromic iridocyclitis. I think Abhilasha can take that.
Yes, about this, I think it was straightforward that phacoemulsification is not tough. I mean, cataract surgery is not tough in Fuchs uveitis and it is not associated with complications. And iris nodules around the pupil are typical findings. Cataract is seen at presentation in these cases. And of course, the Amsler sign, which is a very important sign in Fuchs. You do gonioscopy and you see those abnormal vessels bridging the trabecular meshwork, and these vessels tend to bleed. They are not new vessels, but they tend to bleed during cataract surgery. So Fuchs uveitis is one of the very few things that you must know as a postgraduate, and you must know how to differentiate it from intermediate uveitis. So please learn everything about Fuchs.
And sir, a little heads up for the emulsion question. I think a lot of people got confused about that as well. I think they went with the white precipitate that we see on the eye drops.
Yeah, that emulsion, that white precipitate is called cake formation, which typically is seen in suspension. So prednisolone, what happens? You have to shake the bottle to mix it because there will be a solvent and there will be aqueous. So you have to shake it properly so that it can attain desired level of concentration. Now, there is a very interesting study conducted long back, almost I think 15 or 20 years back. So they found that you need to shake the bottle at least 15 times to achieve the desired level of concentration. So that's all about the suspension. So that's why they find that the suspension, they attain very good concentration in the anterior chamber. But only problem is the compliance, because patient needs to shake the bottle very carefully. And the second problem is the suspension. They have a problem of caking formation. So they form some particulate matter, and that causes a lot of foreign body sensation or irritation to the patient. So that's why they preferred that using that emulsion. So emulsion, as I said, it is basically a mixture of two liquids which is unmixable. And difluprednate is one of the very popularly used corticosteroid nowadays, and it has it's an emulsion, and it is basically a oil in water emulsion.
Right, sir. So I'll just go back to the podium. So this is Ashna at the third position. Ashna, have you joined? Gautamar, he has joined us. And the first position, Aditya, he has also joined us. And PG Ups and Nick are also requested to please join in with us. If you guys have not registered my number, I'll repeat it again: 8826612008. I will stop sharing the Kahoot screen so we can have the winners on screen. Sunilji, I believe everybody had joined in, right?
Only Dr. Aditya joined.
Okay, I admitted 2 more people.
Maybe they will just
okay. Yeah. So Gautamar is also here. Aditya, could you please introduce yourself? I mean, like, this is just a formality's sake, but please go ahead and introduce yourself.
Hi. So I'm Aditya. I'm doing my UVA and Medical Retina Fellowship at Bangalore.
So excellent. And I must add one part. So I had met Aditya at the COSCON conference, is that right? This is before the UVA session even began, and he very enthusiastically came and he said that I would like to join the iFocus classes online for the UVA module. I said it's for the postgraduates, and he's like, no, I need to still learn. I think that's a very good spirit, and I appreciate that very much, Aditya. That's very good, and you've been there consistently throughout the sessions, and this is probably an example to the postgraduates that see it's not a short process. It's a continuous process of learning. Even as fellows in oculoplasty and ocular oncology, we are also learning a lot about uveitis. So everything lands up helping us in one phase or the other. And Aditya has been there consistently for the lecture. So he has been hearing all the sessions. He's been hearing the speakers, and that helps you in keeping it in mind. Whenever a patient comes in your clinic, you might just look at them and be like, okay, I've heard about it somewhere. Like Partho sir was talking about it, or Abhilasha ma'am had discussed this particular pointer. It helps you. Even I was on the other side 3 years back, and even I landed up learning that way. I remember the same question was asked in my Viva as well. So it helps you a lot. You don't need to be joining it live, but at the same time, if you land up seeing it all together also, that's fine, because your timing might not match. So that's okay. You don't need to be there for the live sessions. Ashna, would you like to introduce yourself?
Hello, ma'am. I did my DNB from Nethralaya, Chennai. I finished in June 22 and I'm working in Bombay right now as a senior resident.
That's wonderful.
Thank you, sir.
Aditya, you have attended almost all. No, I have seen you in all. That's the secret of your success, I guess.
And it's very humble about it.
Interesting. I have worked in I think one article we have worked together, right?
On GPA.
Correct. Excellent.
That's great. Dr. Gautam, would you like to please introduce yourself?
Good evening, everyone. I am Dr. Gautam. I am third year resident from Jyotirmay, Pondicherry.
Okay, he's a resident. Excellent.
Congratulations.
Thank you.
So we still need to know who is PG Ops and Nick, but I think they have not been able to join in. However, that's really, really nice participation from all. Would you both like to say something, sir and ma'am?
I want to know about
PG Ops.
No, it was fantastic, actually, fantastic experience conducting the Uveitis Quiz and this moderating and coordinating this session with Abhilasha, actually. And I think Abhilasha can explain it further.
I am very grateful first to Dr. Santosh Soumyava sir for giving me this opportunity to be a part of iFocus Uveitis module. And next, I'd like to thank Partho sir for always being there, big support always. And of course, our four musketeers, Dr. Rolika, Dr. Subhav, Dr. Shefali and Ruju. And they are so well coordinated and so hardworking, and they do their clinical work, surgeries, and then come to iFocus and focus on not only oncology, they focus on uvea. And it was a great learning experience for me as well. For the last 4 months, I heard some excellent lectures from all the speakers, and I got to ask questions and moderate the sessions. It was a very good learning experience for me. And of course, today's quiz was exceptional. And we see such hardworking students and fellows, PGs, they are working so hard. And now actually uveitis has changed a lot. There is so much to learn now than what it was 10 years back. Especially we know about so many new signs and imaging features. So it's very important to keep ourselves up to date. And it's an excellent platform, iFocus. And I thank everyone once again. And congratulations to all the winners, Dr. Aditya, Dr. Gautam, and Dr. Ashna. And good luck to all of you, and especially Dr. Gautam, because he's a resident and he has to write the exam. So all the best, and hope it was useful for everyone. Thank you.
Thank you, ma'am. Thanks to all the participants. The winners are requested to please send me some information about yourself so that I can send you guys the certificates. And the prizes for the session will be announced in the next class by Dr. Santosh Soumyava sir himself. So be there. And just another heads up that now onwards the sessions will be shifted to Monday and Wednesday temporarily for the next 2 months. So the sessions will be happening on Monday, the same time 8 to 9, and Wednesday, the same time 8 to 9. And the next class will be the master class and the last word by Professor Amod Gupta sir. He was not keeping well, so he was not there with us throughout the sessions, but he has agreed to come there with us for that one session despite of his health. So kudos to him. And that will be on April 3rd. So see you all there. So thank you, ma'am. Thank you, sir, for being there with us.
Thank you. Congratulations to the winner once again. And thanks to Santosh Soumyava sir for all this. Thank you. Good night.
Thank you, everyone.
Good night.
Good night. Signing off sharp at 9.